Buongiorno. This will be the last word in Italian, I guess. I've tried to translate the slides in Italian, but it's Google Italian. So if from time to time it's not correct, please interrupt or whatsoever. I want to talk a little bit about patient dosimetry because I think that it's very important not only to control the technical parameters of your digital system, but also to look if the doses that are really administered to patients are still good. And I will show you some examples. So we did some quality control on our digital systems. The systems you see are all flat panels or CTs. I have to warn you that there is a big difference between what we think the patient gets as a dose and what is really administered. First of all, I'm not working in Ghent. I used to be there, but now I'm working in Roeselare. And if you want, Belgium is a really small country, so you see London and Paris and Amsterdam and Brussels, and between Bruges, Ghent, there you find a hospital in Roeselare. We have something like 915 beds. We do radiotherapy, we do heart surgery, the big things we do. And we also have 5 physicists in our hospital. This is the overview of the beds for people who are interested. The first question I want to ask to you is, patient dosimetry, does it matter? And I think we all should say, yes it does. What you find here, what you see in the upper part is the result research that has been done and has also been published in the Lancet, I guess, where you see what the differences are between the countries giving the patients and also the risk that is connected with on the complete patient population. What we see is that in Japan, 3% of the cancer is induced by medical applications. And I'm sorry to say it, but it's practically everything from radiology. When you have nuclear medicine, when you have radiotherapy, that's a complete other class of the population, but radiology is for almost everyone. Here you see an overview of the Belgian situation, and you see the dosimetry in 2003 that 51% is CT, is so computed tomography, and then you have some spine angiography. But at this moment we have in Belgium no values about operation theater. We just don't have it. So we don't know what happens there. And I think that working on automatic registration of doses should give us some more information about that. When you start with quality, people talk about the circle of Deming, which says plan, do, check, act. I don't know if that's a little bit known, but it says, okay, say first how you're going to work. And afterwards, you have to write it down, you have to think about it, and you have to know how you're going to work. I think for most physicists, that's no problem. That's also but how we work and how the medical world works is not always the same. Second thing is, you have to train your people. You have to explain the idea, and you have to standardize it. So that you administer every time the same doses and you work on the same time. And afterwards you have to check it. Then you have to measure, you have to control your system. like with DAP or CTDI or DLP. You have to get some figures about it. And the act part is the optimize. So I give an example. If you have an RX lumbal spine, I think it's no use that you start collecting the AP values if you don't know how people work on the ward, how many photos they give. Do they use fluoroscopy? Don't they use it? But in our country, the Belgian legislation is still focused on measuring patient dose and measuring it on a manually way. So writing down, like in the Middle Ages. I know there's a beautiful center here in Cremona from the Middle Ages, but on patient dosimetry we should be a little bit further, I guess. So we have a little part of the legislation which says that for every individual procedure we should be able to calculate doses afterwards. And the measuring methods are validated by the physicist, so he or she can choose what technology here wants to work with. The goals are, of course, to optimize the patient dose in regard to the image quality, because that's the definition of our job as a physicist, and also to calculate doses of individual patients, dose of organs, uterus and gonads, comparing them with a kind of reference, which they call in English dose level reference. I don't know if the Italian translation is that, but it means that is the doses where you should not be above. Try to prevent deterministic effects in interventional radiology, and also these measurements should be used for a Belgian DRL. So let's take a look at CT, because I think that CT is one of the modalities which gives the most dose to our patients. Then we are asked to fill in CT skull, brain, sinuses, cervical and lumbal spine, etc., etc. A lot of different procedures. And for the children, we need also to add the length and the weight, H and Zender, which is logical. But we have to say, of course, we have to note CTD volume and DLP. And for all cases, those parameters must be accessible. Only the relevant dose indications, but it's not said what it means. In Belgium, we have to register every 3 years 20 patients for one examination. And I think that this is not useful. And I will show you why it's not useful. I'll give you already one thing. When I compare the data which are written down manually and which are generated by computer, I see that the values are better when they're written down. Because at that moment, people are very much focused and they will not make any faults. But humans make faults. So you will not see that. Exception only the procedures that at least 5 times a month are executed. This is the registration formula for the Belgian legislation. So in Brussels they get thousands of papers of that, and also for children. Now, after 5 or 6 years of legislation, we managed to make DRLs. And these DRLs are really very, very, very small part of the radiology. So the only thing we have is classical RX, like thoraxes, chest, abdomens, lumbal spines, skulls, and we have also a little bit about CT, the DLPs. Now, it's a focus on manual registration. The first problem is that it's very unreliable. You have 74.6 or 7.46. That's a factor 10. Usually on the wards, they don't know what unit it is. Sometimes, and this is which different modalities give. In some, it's in deci, gray centimeter square. In some, it's in micro gray meter square. Some are in gray centimeter square. If you don't know, as a physicist, or if you get some values and you don't know what the unit is, forget the registration, forget the values you get. It's of course an unpleasant work for nurses and technicians, and it's statistically completely irrelevant if you have only 20 exams. Another problem is the inaccurate description of the procedure. So they say CT abdomen. What is a CT abdomen? I have a CT from this. It can be a CT abdomen. I think they should use a good code of a good description. It could be like the American red legs from the RSNA, which is made, or I use the Belgian reimbursement codes, because that's a language everyone understands. That's money. Everyone understands euro. So the amount of procedures has also become bigger, though I think it's better to monitor a few parameters good and well defined. Here you find from, and that's new, cardiology. From cardiology, they want us to note down dilatation of stenting of the arteria. You must say if it's iliac, renalis, femoralis, carotis, or whatsoever. This thing is the complete activity of a cath lab. If you have EFO, which is electrophysiology, they say with or without ablation. I hope you know what ablation is. That's the problem with the rhythm of the heart. Here you have from our automatic system only the ablations. And you see that there is an enormous difference between these procedures. So just say we note the electrophysiology is the same as we say we note the let's say the angiography or we note the CT. If you don't say what you are registering, the only thing you get is a cloud of data with which you can do nothing at all. We don't have a word about pediatry, though we had a big study on CT, nothing on fluoroscopy. In interventional radiology, we have very high doses, and even with flat panels, we have in the 21st century, we have injuries of skin which don't heal. I'm very sorry to say it. I've seen a study on cerebral embolization in France, which was a big scandal for the head, the hair falling out and all that. Mammography, we don't have a difference between if it's craniocaudal or also not the thickness of the breast. If you have a breast of 7 centimeters, I think it's normal that you will have more dose than if you have a breast of 3 centimeters. What about the rest? We don't talk about stomatology, about the dentist. Though there is an enormous proliferation of those when we change from an intraoral device to a panoramic device or even to a cone beam CT. It's not been talking about. Operation theater, we don't know what happens there. So I have some remarks on the legislation. Again, first think and say what you want to do and then start measuring. I have here some figures which I have from the old days. Like the old days, before we bought a program, we had our own in the years of 2007. I met with my team, made a kind of tool to measure automatically all doses. What do you see here? That is the normal chest, thorax, FAS and profile. You know, it's the procedure which is done the most in a hospital. If you take 50 patients, then you have like median of 0.85. Okay? But if you start calculating the interval of confidence, then you find that it will be for 90% sure between 0.6 and 1.3. Fantastic. You don't know nothing with these 50 patients. But if you then start with 1,600 patients, then you find that the median is 1, and that it's between 0.95 and 1.02. So I say, if you want to have decent values, decent patient dosimetry, one must think about automatization and registration. Yeah? I'll talk you very short. There are different kind of techniques for automatic registration of those. The first is MPBS, which is called Modality Performed Procedure Step. So it's something which was created in the 90s, 1988, and is a kind of email for dose. Let's say it like that. The modality sends out a message, and the thing is that you have a start and a stop, and you have to get that dose. In 2007, we made our own system with a CR reader of Kodak, a DAP meter of Welliver, and Auris, which is a Belgian company. The next step is DICOM standard is DICOM radiation structure reader. That's the thing you need to have. When you think about automatic dose registration, and if it's possible to have it on your devices, ask for structured report. There are, this is not this company, this is not Siemens or Philips or Toshiba or whatsoever, it's DICOM standard. The thing is that this modality creates a report instead of a message, and that is much more stable. What you also can do is collecting the data out of the DICOM header. That's much more complex, and a recalculation is needed, and sometimes you lose a little bit of information, especially when you have classical RX and you take, let's say, a knee, and they position with scopy. You will not find that dose in the DICOM header, though it is administered to the patient. So have to be careful about that. This is, if you want to implement it, a scheme we made for radiology on CR, which is, you know what CR is? Phosphor, phosphor plates, cassettes. I think this is interesting. What is this? This is cath lab. One procedure, diagnostic coronography. No interventions, no PCIs, no metal, no stenting, no angioplasty. Just look what the problem is and give that dose. What you see here, is that we are a teaching hospital. And this modality is only used for doctors which are learning the job. I'm very sorry, but we have here much higher dose. What you also see that if you talk with the doctors, then the dose goes down. And after a few months, especially after the holidays, you see that it goes up. And then you have to re-talk with the doctors, I guess. But the thing is, you can do on technical parameters what you want, but if you have for the same procedure, this dose, this has nothing to do with our work, but with the way it is worked with the device. Okay, this slide is from GE. This is the thing we bought, and which merely is a kind of email server, nothing more, nothing less. What it does, it collects all the doses that it gets and thus analyzes with it, and it's a very practical tool because on a few minutes you see a lot. And from a physicist, I'm not saying that you have to buy this system, but think of a system for automatic registration. On that, then you can really see what happens in your hospital. And can you really see what is the difference between the theory and the practice. What you have, that is that all those related data of the patients are in a modality. So you have here, I don't know if you can read it, but I took the Italian version for the screenshots. This is mammography. Here you see what is done in a cath lab for a procedure. So at this moment, we have all our CTs, 2 mammographies, flat panel, Siemens Luminos flat panel, Philips Eleva, Angio. Our classical RX are on the system, our cath labs, and we have the different sources I talked about. So we have MPPS radiation structured report on Siemens, which is the most stable system we have, and data collection of DICOM header. What you see here is values of mammography. So every patient which has had a mammography comes in our system. But it's more than those. That is also, I would give as an idea, if you think of buying a system, try to get as much as technical parameters. Not only the dose, but which KV, which acquisition time, MA, scan length, slide thickness. The slice thickness is very important in dosimetry. We all know when you take very slow, very small thicknesses, you get a much higher dose on CT than if you have thicker pitch, phantom. I'm not going to write them all down or read them all down, but you need to have enough information. We started in March, and I will say directly, not plug and play. Not plug and play. There's a lot of work to do, coordination between the connection specialist, modality, dose watch. You need to validate as physicists everything before it works. They need to make a special filter. You can upload historical data, that's also possible. The problem, what they are still working on it, is for mammography. At this moment, we have a GE Essential. The MPPS gives not enough information. The only thing we get is the total dose, total average mean dose from the breast, and the number of acquisitions. You don't know which anode filter combination is used, if it's rhodium or if it's molybdenum or whatsoever. That is really important information. The KV you need to know, the thickness of the breast you need to know. And this is work in progress, and they know it because this information is in the DICOM header. But the thing is at this moment that the MPPS that is sent out doesn't give all the information. Just to say that it's a fantastic tool, but not everything works at this moment. What we also see, this is with a Philips Diagnost flat panel, that you see that in dose watch you find a 0 line. For the same patient when you have 2 different kinds of procedures. When you go then with a special tool in the DICOM header, then you find the same value, but and the other is the acquisition time. But this value is not, it doesn't come in dose watch. So there is a problem with the MPPS. Is it the sending part of the receiving part? We don't know at this moment, but my team is working on it to find out. So it's not all plug and play from the first time. Of course, what you can do almost immediately is get the DRLs. That is the combination with the DRLs. I gave them to you. That's 2 seconds of work. There is a built-in analysis, and you have directly, you see here that for lumbar spine, the DRL, the best part of Belgium works with 75, and you have to pass for 210. So we have here 49. But the thing is that this is not correct. Philips gives more with the standard than Siemens at this moment. Siemens is at something like 50. Philips works with 75, which is good, eh? But Siemens is now better. The thing is also, what I'm talking about, when I change values, the doctors, they know it, but I don't see the difference in the image quality. Eh? Let that be. You can do a lot of dose reduction without medical doctors noticing anything. Here you have a comparison between old and new technology. So Omnidiagnost, Diagnost 96, as the name says it, it's from the 20th century. You see that there is in the standard a lot of differences. And I also want to mention that we have a lot of data, enough data. So if you have 300 patients, you can say something. If you have 20 patients, forget it. What you also see is the effect of fluoroscopy. Here, what you here see is a thorax. You know, the chest. Two cliches. You find here the exposure time. The exposure time, the median of the old system, the mean is something like 7 seconds. If you take a photo, that's in milliseconds, okay? What you see here, that is, that on the old system, where there was fluoroscopy, on every patient, they put on the pedal to give fluoroscopy, to get the patient right, but that gives a lot of dose, which is not necessary. And if you go and you read the manual, it is said, we don't give fluoroscopy to position the patient. But if you see in practice, you see they do, and a lot, eh? And if you see then, like here for your thorax, we have now something like 3 or 5. And previously, we had a dose which was the double, due to fluoroscopy, which we didn't know. Then we started with pediatric CT of the brain. But first we had a lot of zero values, so we had to adapt a little bit. Of course, you need to compare between the packs and which is in dose watch. And there you see that there are slightly differences. That comes because a dose watch recalculates the DLP out of the values in the DICOM header. But it's between, it's in 2%, so that's good. So, what is written down in our quality manual, which we have, that we have specific procedures for pediatry. Thus, how the things are done is written down here. So we have from every procedure how we make it. And we see that we have 2 different scan protocols for our 2 CTs, which is not that good. But now, the practice. 3 years ago, I did an optimization for little children where I reduced the dose with 3, not percent, divided by 3, okay? And what do I see when I have the dose watch? That 20% of our children were scanned with the adult protocol. You have a child of 6 months, that's a fist, the head, and they scan it with the adult protocol. Because for me, that's something like to explode. And the thing is, you can work on people, but if you don't have the tools to control it, people, especially CT brain, is especially for car accidents. In the weekend, in the night, you know, polytrauma in the night. And the people that work there are not almost so good experienced. And what they do, they work the way they used to do 20 years ago. They know one protocol, CT polytrauma, and they also scan the little children with the adult program. So I think that's quite interesting. What you also see, and that's even worse, you know what mass modulation is? You know that the MA will change if you go through the body. But the thing is, there is a threshold from 100 MA. So if you have a small body, it will not work. So it will give the high dose. That is not to do with the CT, but the way you work with it. So this is the same thing, but for any other machine. What we also found is abnormal high values. And if you go and look there, and this is a CT brain, you see the problem? Yeah, of course, it's not the brain here. It's the middle of the part of the body, so that are false as well. Findings, differences between the manual and actual procedures. You can do a lot, and that will also give a lot. Yes, I'm gonna. Without iterative reconstruction. You heard about Azir and other iterative constructions. I say to you, with a good knowledge of your physics and a good work together with your doctors, you can make, we have for an 8-slice CT scanner, we have approximately the same dose as for, and the next slide is from the website of GE. Just if you can talk with your doctors about what is the medical quality they need. So if you find here optimized something like 300 milligauge centimeter, and this is from Veo, GE, the newest, says 240. Of course, the quality is better. That's for sure. And the quality of the image is better. But the thing is, do you need that kind of quality? They have to talk with your medical doctors. Okay, conclusion. I think validation is needed. It's not plug and play. It's part of the 4th stadium of the circle of Deming. First, it's only if you have already a good quality program that you must start with measuring. Analysis of the systematic faults, that's the big issue for an automatic registration system. You need a program which is more than a database of depth values. You can do nothing with a program which gives only your depth values. You have to have the relevant dose information and acquisition characteristics. I think it's a powerful tool for a physicist. That most recent modalities that they don't always give the lowest dose. That you need a good understanding of your basics of radiology. And finally, and that's my last slide, in every email we think about the environment. Right? Why wouldn't we think about the dose for every exam we take? Why wouldn't we give such a CT and say on it, this is a low dose exam, because this was a child and we didn't need all the information. We didn't need all that high dose. I think making the medically relevant images for the lowest dose for our patients, that's our job. And we should be proud of noisy images. Thank you very much.